for joining us. For have joined on time. Thank you so much for taking out time for joining us today. So yesterday we discussed a little bit about today's session, like what is going to happen today. Today we'll be taking you through mostly like an experience sharing from Dr. Reena's side, how she has taken the session on SHS, or I mean, it should be an interactive session where you can share what you do in your practice, what can be taken from her experience, or what you can add on to the experience that she already has. Thank you so much, Dr. Reena, for coming again for this program. Dr. Reena is heading the Department of Continuing Medical Education at CMC Vellore. And she was a consultant radiation oncologist in CMC Vellore for many years. And she started the palliative care unit way back in 2004. And since then, for many years, she's been associated with Palim, and she's played a very major role in developing the curriculum or designing this faculty development program. She's helped us as a mentor for all these programs. Thank you so much, ma'am, for being with us for today's session. And over to you.
Yeah, sorry. Thank you, Sridevi, and thank you all for joining this
Ma'am, your voice is very low.
Is it? Oh, okay. Is it better now?
I mean, slightly better. I don't know what it is because we keep it in the full volume. Now I can hear. Can participants confirm whether you can hear Dr. Reena?
Can you hear me now?
Yes, ma'am. Yes.
Okay. If it dips again in between, just tell me again. I'll try to speak up louder.
Sure, ma'am.
Okay. Um, can you see my screen?
Yes, ma'am, we can.
Okay. It's not going to slideshow for some reason. Okay. Most of my talk is actually on ethics and communication, and how actually in some ways they capture also SHS. Um, how many of you here are already teaching communication and ethics? Just, just put a thumbs up or in the chat box in your medical colleges. Yes or no, whichever way. Yeah. So we have divided responses. Over the course of this hour, I would like to look at some ways in which even a small department could introduce ethics or communication into the curriculum. I will request you to identify key components of communication in a teaching video and identify 4 cardinal principles of medical ethics in a case scenario. Like Dr. Sridevi mentioned, I started my life as a radiotherapist, my professional life. And when I was a lecturer or an assistant professor in radiotherapy, I was asked to take 2 classes for the medical students. Now, as you know, radiotherapy is not a major medical student posting. And at that time, palliative care was not a subject at all. And I myself had not undergone any training in palliative care. In fact, my first training was with Dr. Rajgopal when he was in Calicut in 98. So I used to teach them about radiotherapy and radiotherapy techniques and common cancers treated with radiation. But it struck me that your average MBBS student is not going to become a radiotherapist. So, what does he really need in this little time that I have with them? So, what would you suggest? What should we what should we teach them? A medical student who's posted with us, which will be of some value to what he's going to practice later if he doesn't become a radiotherapist. You can unmute and speak as well. Basic outline, yes, I have to do justice to my subject which I've been allotted. How to approach a patient with cancer, communication issues. Now, those are actually very important, except that at that point in my own life, I had not heard about the term communication skills or the steps of breaking bad news. But I had heard about cancer pain management. And I'd heard about cancer pain management from Dr. Robert Twycross, who was at that time working in the University of Oxford. And one of the things he told us was start low, go slow, but do so. And a couple of years later, when I came to Calicut, where Dr. Rajgopal was then, I saw this start low, go slow, but do so in action. Because in a very, I had thought that to do palliative care, to really address suffering, my impression was of St. Christopher's Hospice. You have a big setup with a lot of trained nurses, trained staff, lot of donations. But here I saw how in a government hospital, with a clinic and with a volunteer, it was truly possible to understand the full dimensions of suffering. And later I was privileged to be able to train with Dr. Twycross for a couple of years. And when I came back, I began to think that even when I talk about palliative care, I have choices, isn't it? So I have two columns here. One column is pain prescription, evidence base for different opioids and different models of palliative care delivery. The other column is pain prescription, communication, and ethics case scenarios. So, can you just kind of put in your votes? How many prefer the left column? How many prefer the right column? You can put it into the chat box again. So, the medical education principle here, I mean, most of you are medical college faculty, is that even though students come to our departments, they're not coming to be made into specialists in our field. If they do choose to do that later, then they'll come to us as postgraduates. But so the left column actually are the things which might interest me as a specialist palliative care person. What's the evidence base for different opioids? What are the strengths and weaknesses of different models of palliative care delivery? But for a student who's not heard the term palliative care, we have to kind of, like our mothers would put in some vegetables in between our sandwich. We have to put in these principles into the areas that they see as relevant and they see as connected with their examination and connected with how, as doctors, they can make a difference to patient. So that is why I thought, let me look at areas which are beyond radiotherapy or palliative care, but connected to the rest of the curriculum as well. It's beyond the fascinating frontiers of my specialty to global competencies and skills that can be applied across clinical areas and beyond MBBS examinations. Now, back in 2002, this was um, a little offbeat. Like actually, CMC 2 3 years earlier, somebody had started teaching communication and a little bit of ethics, but it was not part of the NMC curriculum. Well, NMC was called Medical Council of India at that point. Now it is easier for us to justify this because, as you know, the NMC has stated that not only is our Indian medical graduate going to be a clinician, he has to be a leader, communicator, lifelong learner, and professional. And so, in these roles of communicator and professional, in the ATCOM modules that we are called to teach, we can weave in the role based competencies of communication and ethics. And as you know, the four cardinal principles of medical ethics are autonomy, beneficence, non maleficence, and justice. This Does anybody know who first kind of spelt out these principles? If you do, you can put it in the chat box. Who first spelt out these principles and why? Okay, it's a pair called Bisham and Childress. Okay, and the reason Bisham and Childress wrote this up sometime in the late 1980s is that we have culture, and culturally there may be different things that are acceptable or not acceptable. Like people may have religious views against blood transfusion. There may be religious views against abortion. So, how can we have broad, overarching principles which almost every culture or every religion considers good and which can be used as a framework when we have to make medical decisions? Okay, so these four principles, whether you're Hindu or Muslim or Christian or atheist, uh, we can agree that doing good is good. We should try and avoid doing harm. We should respect an individual's choices, but we should balance that with a fair distribution of limited resources. Now, before palliative care, when I had heard of medical ethics, we sometimes discussed ethical dilemmas. It would be about complex cutting edge topics, like organ donation, gender transitions. Now, if you have to choose to teach ethics, which do you think would be a more worthwhile thing for teaching our medical students and our palliative care registrars? Cutting edge topics or regular clinical scenarios? Again, you can just put it into the chat box. It just makes it a little less monotonous for everybody if we have our viewpoints. Like we all agree that although they may be less dramatic, this is probably more worthwhile. Why do we say that? Why do we think that's more worthwhile? Just some simple basic reasons. Yes, one is that they can actually apply it. And the second thing is that they realize that this is not some theoretical jargon. Okay? It's not some theoretical jargon. Exactly. It is relevant. So thank you for sharing those 2 points. Autonomy, a big element of autonomy in advanced disease is about informed consent. And informed consent means adequate information to give a well thought out decision. So since my background was in oncology, I used to use examples from cancer, but each of you can use examples from your own subjects because that is what they're expecting from you when they come to you. So, and I usually use true examples. So, one example was about a 45-year-old school teacher from Assam who had metastatic cancer with supraclavicular nodes. And he came, very far away from Assam to Tamil Nadu, took first line chemotherapy. When the disease progressed, he took second line chemotherapy. And when the disease progressed again, he finally understood the cancer was incurable and he came to palliative care. And what he told me then made my heart break. He said, I have two small children and my family depends on me. I took the best available treatment in order to be cured for their sake. I sold off my land and my house. Now there is nothing left for them and I am going to die. Why did the doctors fool me? Actually, he used the term fool me. Now I know none of my colleagues wanted to fool him. And I know all my colleagues get a fixed salary. Nobody gets any cut based on any incentive based on how many patients they treat with what. But, this poor man who trusted us and came here had felt this way. So, what are the elements of serious health related suffering in this case? Can you just put in 1 or 2 points? If you were this man, or if you were the mother of these children, what are the elements? Yes, psychosocial, financial. Really, in his case, the cancer was only the tip of the iceberg. The real reason why he was having treatment for the cancer was for the sake of his family. What did Dame Cicely Saunders, the founder of palliative care, speak of as the 4 elements of total pain? What are the domains? Total pain had 4 domains. So, spiritual, emotional, and you mentioned the other, one has been mentioned, social, which is the biggest thing here, and physical. Okay? So, if we take a case scenario, it is easier for students to understand how these things are playing day in and day out. Okay, it's not just preaching to them about physical, emotional, social, and spiritual suffering. So, was informed consent truly well informed here? Answer is no. So, we can ask the students, how could we recommend treatment options better in incurable disease? What would be your suggestions? So, the first thing is to be honest but kind in explaining the intent of treatment. Okay? Now, I don't want to blurt out, you are going to die, so this is no use. We can't say that. But first, I have to say when the cancer is in this stage, it is difficult to cure. That is still ambiguous. With medicines, we may be able to reduce it for some months. That puts an honest time frame on it. Okay? Yes. So before we explain the pros and cons, we tell them the limitations that we face. Then we give options which include the option of supportive care. Okay? So, expensive drugs which temporarily reduce the size of the tumor, we don't say which may cause a complete remission, cost this much per month. Some patients want something cheaper at this much per month because anyway the cancer is not curable. And others may say that we don't even want chemotherapy, we only want symptomatic treatment or radiotherapy. So then all of these are there as options. Okay, like if you go to buy a phone, if the shopkeeper shows you that we have only this high end model, you don't really have a choice. So after you have explained the cause, what will you do next? Thank you very much. See what he has understood. But before seeing what he has understood, what would you do at this point? What would you do if you'd gone to the shop and the shopkeeper had explained the options to you? How many of you would straight away buy that phone then and there? If you say, how many would not? You can put in a yes or no over there. So so I sometimes use an analogy like this with the students: phone, laptop, whatever they are in the process of buying. That if for a gadget or an electronic gadget, when you hear the options, you still don't want to take a choice immediately. For this man for whom it's a matter of life and death, exactly, like you say, shouldn't we give him time to discuss with his family and decide? And for him to be able to discuss with his family, he needs to know the beneficence and the maleficence. The beneficence maybe not in everybody, but maybe in about half the patients. Improve survival, not forever, maybe for some months. If he responds, he may have symptomatic improvement. But the burdens are, of course, the cost and the side effects. And for this man who is coming from Assam, what is another toxicity? What's another toxicity of anti cancer treatment besides side effects? Yes, the toxicity of time. The toxicity of time costs. Um, Only recently in oncology journals, we are really beginning to recognize this, and there are even papers published on it. If you have 5 months left and the chemotherapy gives you 2 months more, but if you're going to spend 6 of those 7 months in a faraway hospital, what have you actually gained? So then again, we summarize these options, give them time to decide, and I tell students that you can always ask them to come back to the next clinic. They don't have to take that decision that day. If they do have to take that decision that day for some reason, you can still call them back after an hour or two. Now, we may do our best about explaining options, but can patients have unrealistic options even when we have explained prognosis? Yes or no? Just very, very commonly, isn't it? Huh? So, this is another true patient that I saw. Okay, he was a manual laborer who had pancreatic cancer and multiple liver mets. Young man in his 30s. He had come to hospital. He'd been told that the best chemotherapy would reduce the size of the tumor but not cure it completely. Nobody was telling him it's going to cure. But he insists that he wants a treatment. and he wants to sell everything and take a big loan. Now, this man's wife's brother, actually came to casualty saying, I want to start it as soon as possible. Now, this man's wife's brother came to us and said, they have nothing other than this little house. And if he's selling the house and taking a loan, my sister's not only going to be a widow, she won't have a home, she will be under debt for the rest of her life. Please tell him not to do this. So, how would you approach this situation? Any suggestions? So, so sometimes the students will say, we will explain to him that um, it's not curable, he should not waste money, he should save money for his children. And and what will so that's what the registrar tried. But this man, he started getting angry. He said, why are you refusing me the best treatment? So exactly. So thank you, Dr. Priya and Dr. Sairo. What we need to tell them is that when somebody seems to be making an unreasonable decision, when you can't understand why, ask them, okay, this is what you want. We hear that, but can you tell us what you're expecting from this? What is their perspective? So then we told that to the patient, and his answer was very immediate, and it was a little bit of a surprise to us. Okay? He said, I know the cancer is not going to be cured, but at least if I take the expensive treatment, I'll get 15, 20 years more. And during that time, my children will grow up, and then it does not matter what happens to me. Okay? So it's not that he wanted to, take away the resources from his children. His thinking was that if we are offering treatment worth lakhs, see, diabetes is not curable, hypertension is not curable. There are so many diseases that are not curable, but you take treatment, you can keep it under control. And that was his expectation here. So once we know where the communication gap lies in an ethical decision, then we can address that particular issue. It's like when we take an exam with students, and we do a small pre-test and we see what they don't understand, then we can address that issue. And in this case, I realized maybe it's better if I draw something rather than keep repeating the same thing. It's not curable, it's not curable. So it takes only 1 or 2 minutes to draw this diagram. Okay? See that your cancer is growing like this. Unfortunately, even with this very expensive treatment, we cannot cure it. Unfortunately, we cannot keep it controlled for years. If we give the treatment, maybe in 1/3 of people, it may come down for a few months, but after that, it will grow again. And without treatment, also, it will grow. Now, in this case, as soon as he saw this, he didn't even need time to decide. He just said, oh, if that's all there is, then just give me something for my pain. I have to go and settle many things for my children. So, here again, this is a point at which we can ask students that do you think this ethical analysis and this communication is as important as taking another X-ray? We can ask them, how do you apply autonomy and justice, beneficence and non-maleficence to this scenario? So, justice, was this an equitable use of resources for a family with young children? Autonomy, was informed consent truly well informed? Beneficence versus non-maleficence, did the benefits of treatment outweigh the burdens? Now, is anyone familiar with the term a priori? When we talk about medical ethics, sometimes you will come across the term a priori. Now, a priori means that each of these ethical principles should be implemented, but if they're conflicting with another ethical principle, then we need to weigh them in the weighing balance. Okay? So, whenever we try to help others, we inevitably risk harming them. There are very few medicines in our pharmacology textbooks that have no side effects. Okay? So, this beneficence, maleficence is something we are doing every day. But healthcare workers who are committed to helping others must therefore consider the principles of beneficence and non maleficence together and aim at producing net benefit over harm. Okay? So, here there's a seesaw or a weighing balance between beneficence and non maleficence. We can have a weighing balance between autonomy and justice. This man's treatment, whereas his children's future, we can have all kinds of weighing balances. Suppose you have a weighing balance between beneficence and autonomy. Can you think of an example for that, where autonomy is conflicting with beneficence? Can somebody give me an example? Okay, so let's take the example of ventilator switch off. Let's take a slightly simpler example. Patient wants treatment when it is risky. Okay, patient wants treatment when it is risky is actually more of non-maleficence conflicting with autonomy. And I have a case scenario for that a little later. Beneficence conflicting with autonomy. One example could be somebody who's refusing COVID vaccine. Okay. We know from evidence that the majority of people may have benefit from the COVID vaccine, but if a person refuses it, can we administer that vaccine to him against his wishes? Yes or no? We cannot, because here autonomy is taking a priori over beneficence. Can you think of an example where, but with a child, if you take your child for doing their DPT vaccine, how many of the children are happily putting for their hand for that injection? They're not, isn't it? But we are still, giving them that painful IM injection. So, what is happening to autonomy and beneficence over here? What is the ethical issue here? Any answers? What is the other jargon which comes in when we are talking about autonomy? There's a word called competence. Okay? So an adult person who is who's physically and mentally competent has the right to refuse treatment that is harmful to him. A child is not yet competent to judge that for himself, and therefore it is a surrogate decision maker who makes a decision, which in this case may be the parent. So Now, one of you spoke about what if the patient wants a treatment that is risky? Okay, here autonomy is conflicting with non-maleficence. And patient autonomy means that recognizing what constitutes benefit for one patient may be harmful or perceived as harmful by another. Which is why, like, we had vaccine refusals. So let me discuss another case with you so that we see how individualized decision making means applying the principles of autonomy, justice, and net benefit to an individual patient with his own specific clinical situation and own priorities. Now, this was also a man whom I saw in the 1990s. He was a retired senior government officer with hormone refractory prostate cancer and bone marrow infiltration, because of which his platelets would keep dropping. And in those days in the 90s, we really didn't have any very worthwhile chemotherapy for this scenario. The burdens clearly outweighed the benefits. But he and his family really wanted to try further chemotherapy. And again, we went through all the benefits, cost, toxicity. Now, what do we do? It seems to us that autonomy is conflicting with non maleficence. So, how do we address the situation? Any suggestions? It's an answer that one of you gave earlier to another question of mine. What was that answer? I think it was Dr. Priya who had given that answer. Again, we'll just ask him why. We acknowledge, okay, you want this treatment, but can you tell us why you are so keen on it? A highly educated man. And then again, when you listen to patients, you realize that there may be other things. And then the family explained that the first child was expected in a few months and they wanted to try and prolong life by at least those few months. Now, this man, the other reason I remember him is because he was actually in a general ward. Okay. Although he had been a retired IAS officer, it's not that he was loaded with money so that he could just keep taking one line of therapy after the other. He had limitations of finances, but he put up with this toxicity. He spent a month in the ward and he survived till a month after that grandchild was born. Okay. So now has the non-maleficence beneficence ratio shifted? It has, hasn't it? So how is this patient's situation different from the previous man? The man with pancreatic cancer who wanted to sell his house and take treatment. What's the difference? Just put your answers in the chat box. The difference lies in which ethical principles? It's a simple answer that this man, he was also incurable, but he was fully aware of the benefits and burdens, and his objectives, while we could not guarantee that he would live till his granddaughter was born, they were realistic. So they were realistic, potentially achievable objectives. Okay? And he was aware of the benefits and burdens and what that meant for him. Whether he took loans, whether he took side effects, I don't know. But for him, that weighing balance was worthwhile. There's quite a nice recent paper by Varkey in which he summarizes these principles. Now, see, sometimes, there is a risk that when we are in palliative care, we can jump into thinking that anybody who comes to us, there is no need for any active treatment. A good palliative care doctor obviously will not think like that, but if we are not systematic, we can make that mistake. Over the years, when I was working on the interface between cancer and palliative care, we have picked up patients who had therapies available, who lived for 10 years, couple who are still alive. So there is no shortcut for that initial clinical assessment and to recognize whether the disease is acute, chronic, reversible, or terminal. Every case that I told you so far was terminal. Whether the goal of treatment is to cure or to palliate, what are the benefits, and what will happen if you do not do treatment. That's also something worth thinking about. But after we have done the clinical assessment, there are a few other steps, and that is what we need to share with our patients. What is the patient's own preference? Like the two cases we saw. What is the quality of life and what constitutes acceptable quality of life? Neutropenia and thrombocytopenia was acceptable quality of life for this man. And what is the context? Family, cultural, spiritual, religious, economic, legal. I remember when I was a first year PG, I had a beautiful woman who had come to the government hospital with breast cancer, and she was expecting twins, first trimester. And she said, however much risk can be reduced, I don't want these babies to have any risk at all. I would rather die than have them survive, than anything happens to them. It was hard for us to see that. She went through a lot of discussions, but she was very clear and very peaceful about that decision. And she had two baby daughters, and she died some months later. Since then, I have seen other patients with breast cancer who found a more intermediate choice. But for her, this was very clearly her choice because after many years of infertility, she had had this pregnancy. Now, in a recent class of ethics for the medical students, I took two pictures from their college day play. So one was a picture which we had on the printed program sheet, and one was a picture of a statue they had made for the stage. Now, does anyone recognize the statue and where it is? Anybody recognizes the statue? Okay, it's the statue of Lady Justice. And the golden one, that model is based on what is there in the main criminal court in London. It's there on the top of that. So now I have two pictures of the statue here. What's the difference between the two pictures? Sorry, let's just go back. What's the difference between the two pictures in the attitude of the two statues? Okay. In one, the sword is raised up, and in the other, the sword is down. What else? What about the eyes? Yes. The statue on the left has a blindfold. The second picture has a balance, but it's a smaller balance. So then I just wanted to leave them a message from the statue because, this picture they knew that as a doctor, we have to use ethical weighing balances, benefits, burdens, autonomy, justice. So that is a yes. But we should not be blind to the individual preferences, the needs, the anxieties, and the context. And we should not be practicing medicine, like some knight or some soldier. We have to practice medicine with respect, humility, and empathy. So, so for me, teaching ethics is a combination of real life clinical case scenarios through which we help them think the principles of the cardinal principles of medical ethics. Any questions at this juncture? So now, as you would have seen, although we see ethics and communication sometimes as two separate talks, you really cannot practice ethics without communication, isn't it? Because so much of our ethics involved find out what the patient is expecting, explain to them clearly. So, how do we teach communication skills in a limited time? Just for me to get an idea, can each of you put down which state you are from and in your college, how many hours you are given for teaching communication? We'll just give 2-3 minutes for that. Which state you belong, which state you are working in, and how many hours you are given for teaching communication to your MBBS students. Thank you, Dr. Narayan. Is that one 3-hour session or multiple? AdCom modules plus 10 years, that's pretty generous. Yeah. So right now, AFTCOM has become a little bit of a lifeboat into which we can put in communication and ethics. But most of the time, we don't have a whole lot of time. And so I'm going to tell you what I did with the limited time I had. We had totally 8 hours for palliative care, into which we had to put ethics, communication, symptom management, pain. Now, definitely, if one takes a lecture, they're not going to take away very much, isn't it? Role plays, demonstration role plays are good, provided you stress the good role play. Why am I saying that? What is the risk otherwise? What is the risk if we don't stress the good role play? Can anybody like to put in an answer there? See, sometimes sometimes I have seen where the teacher will do the bad role play and ask the students to demonstrate the good role play. Now, that is actually really a little bit sad, isn't it? Exactly, huh? Dr. Sairu, the bad role plays are remembered because we make it like Bollywood. It is funny, it is dramatic, huh? And they remember that, and they don't take away what they need to learn about the good role play. So definitely do the good role play and have a good communicator demonstrate that good role play. If you don't have a good role play, use a good video. Uh, and don't make the bad role play too very bad. Okay? Let them have to think a little bit. Why is this bad? Rather than, oh, it is so obviously bad. Because sometimes what happens is that we set our standards so low that things which are not acceptable have kind of become commonplace. So we can use role plays, we've used videos, we did faculty development workshops, and about 2008 for the MCI's Platinum Jubilee, we conducted a national workshop on communication skills in medical education. And some of the things we put in there, actually, it's very nice now to see that these are there in the AdCom module. So you never know. You keep doing little bits here and there, and then suddenly it goes places. Now, often what happens is that when we teach communication, we jump into breaking bad news, isn't it? And we will start with some scenario of somebody with a cancer, and we go in for breaking bad news. Breaking bad news is good because it illustrates many problems, but every patient you see in the OPD, you're not breaking bad news too. So that is why I now prefer to build the foundation on gathering and giving information. Gathering is history taking, giving information is patient education. Because in any clinical encounter, we will have those two elements. And a very useful mnemonic for this gathering information is ICE. Yes, you're teaching Kalamazoo checklist. Huh? That is exactly. Huh? So those were, again, in the 2008 booklet, that's what we recommended because that covers gathering and giving information. So what is ICE? Anyone would like to expand that acronym in the context of communication? Okay, so then we will see that in the second video. Look out for ICE there. And first we will start with a not so good communication video. And let's just have a look at that. Could we play that, please? The clip from WIT.
Sure, ma'am. Play.
Sir. We have the oncologist with the English professor. Do you see him being rude or threatening or anything like that? Not really, isn't it? Huh? But were there any communication gaps here? Do you think communication, the movie is called Wit. What were the communication gaps? Yes, medical jargon. And without being rude, there was a whole lack of empathy, isn't it? He's in a fight with cancer, and she's one of his soldiers in the process. Yes, not enough time. A video like this just illustrates how actually our day-to-day communications can actually be fraught with several problems. Um, yes, and somebody had put ICE was ideas, concerns, expectations. So we'll play another video. This is from an Indian context because sometimes students think, oh, if you put a Western communication video, that is okay in their place, they have time, our patients are not used to that kind of language, etc., etc. So we'll just go on to the next video. And in that, I would like you to identify the ICE and two ethical issues. Yeah. Questions or comments at this point?
Hello.
Yes.
Hi. So what we could understand from this video was, I think, all the benefits of good communication, because you were able to, this patient had just come in for pain, but with communicating with him properly, you were able to understand his concerns and his concepts. You were also able to communicate with him about that his disease was curable, and understand why he didn't want to go in for the curative treatment, and you didn't force him into it. Rather, you addressed the primary treatment for which he had come for, and also told him that he should give it a thought, which was respecting his decision making and autonomy, like he should take the final decision, but giving him all the information in a very open way. So
Thank you for such a nice summary. Yes, and see, the actual consultation part of this is about 10 minutes, 10 or 11, then there's the lecture around it. So again, we ask students, do you think those 10, 11 minutes are a good investment to save a life here? And if we didn't hear him out, we could have just ended this with a prescription and lost a life. So its communication is not just actually in palliative care, it's equally important in curative treatment and in all forms of treatment.
ma'am, I would just like to share an example, like just which happened. So we had just gone for palliative care to a patient, and then when we were talking to her, we understood that she has actually fallen down and had a hip fracture. And we were like, hip fracture is an imminently curable thing. Then, giving time and understanding, we could realize that there were some psychosocial, like, okay, maybe this is not amenable for treatment, she's too old, maybe this cannot be operated. All these things were there in the patient and the family's mind, which while communicating, we were able to sort of, help them around it. And then finally, it decided to go ahead with consulting the ortho doctor and go ahead for treatment. So it was just, yeah, 10-15 minutes well spent.
Exactly, that's what, and it can be quite satisfying, and even for the patient. I will just very briefly touch a little bit about teaching SHS. Let me see if I can share that. Okay. Now, we are trying to teach serious health-related suffering. It's sometimes when we're teaching that to our third and fourth year medical students, it's like asking to design winter wear for this man to people whose life is like this. Okay, our students are young, they are healthy, they are happy, they are not suffering. Most of them are affluent, and here we are trying to sensitize them to all domains of suffering. So I would think through my case scenario a little carefully. Okay, something that they vibe with. So the example I might use is of a medical student who joined a private medical college 2 years ago, and she's the first healthcare professional in her family. And her mother asks her to go to her uncle's house in the village and see her maternal grandmother. And she tells her, you could do this as a role play also. Your grandmother had a stroke 3 months ago, and she was in the ICU for 3 weeks, and she cannot walk and talk. You must go and help her. So now the student, who's the first healthcare professional in her family, says, but what will I do, Amma? Why don't they just admit her in another hospital? That's so then the mother says, don't even suggest that to your uncle, because everything that he saved for your cousin's college education went with that hospital admission. You already know that their business ended during COVID. So suddenly, for this relatively middle class child, you begin to see how healthcare expenses impact even us. And they're a respectable family, and it's very difficult for them when neighbors say that the patient should be admitted in a hospital. So now the student is going to see the grandmother without the option of put her into hospital. And then she sees this grandmother who has had an ischemic stroke, is bedbound with hemiparesis, has pressure sores, screams in pain because of contractures. This is a scenario they could imagine some of them may have seen among their neighbors or their families. And this patient is kept in a separate room because people are scared they'll get an infection. And she's saying, I cannot tolerate this anymore. Please kill me and release me from this burden. So we can give such a case scenario to the students and ask them, what are the different elements of suffering? And then you can ask them, classify those as physical, emotional, social, and spiritual. And then you can give them the definition of serious health related suffering, which is associated with illness or injury of any kind, and which is serious enough that cannot be relieved without medical intervention and when it compromises functioning. Then you can ask them to list 5 conditions with serious health related suffering. It's not just your own specialty. And we could use this figure and ask them to look at the different dots and find out that how many million people are facing suffering due to malignant neoplasms now, how many deaths, how many due to cerebrovascular disease, which is likely to increase. So they might enjoy playing around with a table like that. But that just sensitizes them to the fact that serious health related suffering is not limited to palliative care. But then we can bring in that the suffering that is life limiting or life threatening, that is an area like this case discussion which we had, where palliative care could specially focus. And we can use this definition of palliative care and how it could help patients and families to live without extending life sometimes. And we can tell them that this is one of the areas of healthcare where affordability is not the main barrier. Even having MD, NDM is not necessary. So it's just like asking them, do we teach basic life support only to the MD general medicine and the MD anesthesia doctors? We don't. We know that everybody needs to learn it. So similarly, basic palliative care, not only for all doctors, but even for this medical student, even for a well-meaning member of the community, they can do something about it. So, what kind of help does this grandmother need? Who can provide it? What resources do they need? And if this medical student wants to help his grandmother, what can he do? What can he learn? And again, you can put them in small groups to discuss that. And hopefully, a case scenario might help them apply it to their own context. Then you can bring in the second angle. Can healthcare itself cause suffering in each of these domains? Ask them to give some answers. And they might give you answers like this: treatment toxicity, time toxicity, financial toxicity. And sometimes that itself is an eye opening experience, because every time they're learning, okay, this is what we have to do. And then we have these, really rather depressing statistics that Bangladesh and India are among the 12 countries in the world where the cost of healthcare is compounding suffering more than anywhere else. 55 million Indians are pushed into multi-generational debt below poverty line every year. Now, this family, this case study, they may not have gone below the poverty line. So there are many, many more millions who are losing, where generations are being affected because of inappropriate health care. Some may lose a home, some may lose a future, some may lose a job. And palliative care is an alternative where these heroic treatments are not appropriate. And then, if you want, you could go to another case study from your own specialty. And here, the family is insisting he should be put into the ICU. Now, with your knowledge, you know what are the limitations of that, and how would you communicate that to the family? And although they may not at this point know much about ICU or palliative care, they can still know how to acknowledge that the family wants to do what is best. They can still ask why the family wants to put him in ICU and what they hope for from it. And they can still identify the knowledge and the expectation gap. Okay? At this point, suppose the son says that, we were keeping him at home, but people asked us, how can you do that? You take him to ICU, he'll be fine. How do you address a scenario like that? We can put an ethical framework there. What is the difference between these two cases? A curable breast cancer with septicemia and a stage 4 lung cancer. And to withhold disproportionate non-beneficial treatment is okay. Finally, if they're still feeling uncomfortable, we can ask them the question that how many of us will never die? So, and when we are facing an unavoidable and natural death, maybe everything that we learn in medicine may not necessarily be appropriate there. You could also give them a small exercise like finding a directory of palliative care services in their area. And who knows, that little seed that you have sown might actually help a patient in their acquaintance at some point. Okay, so that is, again, in the limited time that you have, one way in which you could sensitize them to serious health related suffering. Yeah, that video, actually, we just need to edit it a little bit because the titles are missing, are cut off in the playing. So once we do that, I'll be happy to share it with you with a questionnaire, which if you could use it with your students, that would be nice for their suggestions. I'm sorry, it was a little rushed, but any other questions or comments?
if there are any questions, you can unmute or type it in the chat. Can't see any questions. Thank you so much. Yes, Dr. Priya, that's what Madam was mentioning. They're planning to do some editing in the headings, ma'am, and then you will be able to circulate.
That's it. It's because it's getting cut off on top, you know. Some of the text is getting cut off in this version. So I'll just need a professional to edit that for me. And I'll share it to you with a link to a questionnaire so that we could just get some feedback on it as well. Is that all right?
Thank you so much, ma'am, for the session. And somebody has commented for showing your slides on serious health-related suffering. Thank you so much for sharing your experience in teaching students.
Thank you all for joining this movement. You could make a big difference by sowing a few seeds somewhere, and all the very best.
Thank you, all the participants. Tomorrow onwards, we'll be having the group work. So please make sure that you are available for discussion, because if you are, when you can't do it by doing some other task, you have to be in the group for discussion. And we'll be sharing the subtopics for each group in the WhatsApp group. And one person from each group have to present your discussion in the end of your group work. So that also we will be doing tomorrow as soon as we go back into the breakout room. So please do interact with your group members. Try to access the material. So before tomorrow's breakout rooms, please go through the materials that we have shared. Tomorrow's topic is about communication. So we can.
I think it is pain. There was a slide.
Sorry, tomorrow's topic is on pain. So we'll be sharing the topics, subgroups, everything in the WhatsApp group. Please try to access the materials through the Google Drive. You can find a trainer's guide. You can find PPTs, link to necessary reading materials, videos, whichever is relevant for the session, case-based scenarios. So please go through all the materials and be ready for the group work tomorrow. Thank you so much. If you are unable to access, just let us know by the WhatsApp group. We'll be able to help you with that. Thank you so much, ma'am, and thank you so much, all the participants, for joining today. See you all tomorrow at 3 o'clock.
Thank you, Sridevi, Shripriya. Bye.
Thank you, ma'am. Thank you, everyone. See you tomorrow, same time. Take care. Bye bye.
Thank you, ma'am.